Thank you, Dr. Salman, for such a detailed and comprehensive talk on chronic totally occluded vessel. I think carrying on this CTO, our next talk is going to be made by Dr. Tahir Shah. Dr. Tahir Shah works as Associate Professor in Peshawar Medical College. He is going to make his talk on antegrade approach of CTO.
So, thank you very much. After having a detailed discussion by Salman Arain on toolkit, I'm going to have how to approach a CTO and playing with the toolkit. So CTO by definition, it's a total occlusion, which is 3 months at least. This is LAD CTO, which is visible mid-LAD CTO. Now, if you go through it, the learning curve of CTO, stage 1, just antegrade wire escalation, then further stage 2, antegrade wire escalation, and then antegrade dissection and re-entry is the complete. And you go by retrograde stage 3 operators, and then stage 4 who work through epicardial collaterals. There are 7 common principles. The first principle is improvement of symptoms by opening a CTO. Then second is dual coronary angiography and thorough and structured angiographic review should be performed in every case. Third principle, microcatheter is essential for guide wire support. Fourth principle, there are 4 CTO crossing strategies, which is antegrade wire escalation, antegrade dissection and re-entry, retrograde wire escalation, and retrograde dissection and re-entry. Then the fifth principle is change of equipment and technique increases the likelihood of success and improves the efficiency of the procedures. Sixth principle, centers and physicians performing CTO PCI should have the necessary equipment, expertise, experience to optimize success and minimize and manage complications. And then seventh principle is every effort should be made to optimize stent deployment in CTO PCI, including the frequent use of IVUS imaging. This is from paper 2019 Brelakis. Now, how to approach a CTO? Steps, timing, it's better to avoid ad hoc CTO PCI. It will give you a time and decide accordingly. Study the angiogram and have a full-fledged review of the angio, discussion with the family, if needed viability study, if the CTO segment is viable or not viable, that can be done. So timing, no ad hoc PCI. If CTO PCI is indicated or not indicated, the second step you have to think about when you are attempting a CTO PCI. Then analyze the angiogram. The fourth one, plan the strategy. The fifth one is selection of purpose-built hardware, which I already mentioned. Then 6, better is to write step-by-step plan for doing a CTO. And then 7 is always ready to handle complications. So we will start a case scenario and we'll move through it, and how we go by it, we'll see. Patient, chest pain, age 45, functional class 2-3, optimal medical therapy for last 6 months. Examination is unremarkable, risk factor is hypertension and diabetes, ECG is within normal limit with preserved ejection fraction, EF of 64, labs are perfectly normal with creatinine of 1, a slightly increased random blood sugar, and coronary angio performed showing single vessel disease, which is RCA CTO, and failed CTO PCI 2 weeks before when I started attempting that case. This is the clip. You can see RCA CTO in the mid, attempted, so dissection plane is there. How we approach through it. Now, in this case, is the CTO PCI indicated? The first question should be answered, yes or no. If it is yes, the benefit should be more, the patient should get benefit and would not be harmed by the procedure. It depends on the lesion morphology and operator skill. If you think of the benefit, it will be improvement of the angina, improvement of the exercise capacity, and improvement of quality of life. If this can be achieved, then one should attempt PCI of a CTO. So in our case, it is indicated yes, why patient is symptomatic, and it is the only RCA CTO which is totally occluded. So regarding the 7 principle, it is the first principle to go by symptomatic benefit to the patient. Then there is a dedicated CTO program I'm running in my hospital. And then thirdly, a purpose-built device is available with me. So yes, indication, agree with the indication. Then next step, analyze the angiogram. So 20-30 minutes pre-procedure review of angiogram and study coronary CT if it is available. Dual injection is must. Calculate scores, analyze the CTO lesions, particularly proximal cape, lesion itself, distal vessel, and then collaterals. How we do it? The dual injection is performed at low magnification. First inject a donor vessel, wait for 1 to 2 seconds before injecting the CTO vessel. There should be no panning of the machine, semi until contrast clear. This is how perfect dual injection is performed. First, the donor vessel is injected, wait for 2 seconds, then antegrade injection is performed. Now you can identify the exact location, the branches, the nature of the CTO, any tortuosity, calcium, length, each and everything can be defined very perfectly. How you calculate a score? JCTO score is a common score. Other scores are available, but one should just use 1 or 2 scores. So I'm using JCTO, which is having, if a blunt cape, carry 1 score. If there is a calcification in CTO segment, 1 score. If there is an angulation within the body of CTO, not prior to the CTO, not after the CTO, within the body of the CTO, then it carries 1 score. And then occlusion length, if it is more than 20 millimeter, it's 1 score. And if it is a reattempt, then 1 score. On this basis, it defined as, success is defined as 0 score, 1, 2, 3. So difficult, very difficult, intermediate. And this is how I calculated my case. Blunt cape, 1, reattempt, 1, total score of 2. It become difficult, so success rate is 68%. Then progress CTO complication score is being calculated for this patient, and it turned out to be 0 to 2 points, which is 0.2%. Here there is no point carrying a score. So this is the risk. Now analyze the CTO lesion itself, by whom entire cath lab team should be involved in it, the process of studying the CTO. How long? 15 to 30 minutes. And how? It will be proximal cape ambiguity you have to decide. The lesion length should be decided. Then the quality of the distal vessel, and then the collaterals. In my case, how I proceeded it, proximal cape, no tortuosity, and good size vessel, no ambiguity of the cape, it's blunt, difficult to cross, side branch is present, again difficulty arises, and there's no calcification. Then one has to move this, look at this diagram, and you will imagine how the CT play a role. If you look at A marker in the angio, B and C, it's become difficult to decide about the ambiguous cape. But if you look at the CT, you can definitely, it's easier. Marker is not working. So A is the entry point rather than taking it to the B and C. This is the role of CT angio in deciding about the CTO. Then you study the lesion itself. No tortuosity, length is less than 20 millimeter, no calcification, no microchannels are present. Then you study distal vessel, good size vessel, then bifurcation, no calcification, no bypass graft, and then you study collaterals. So good size collaterals, septal, this is Werner classification 2, mild tortuosity, dominance, there is no dominant. If it is a dominant collateral and you work through it in a retrograde case, you will lose a patient can go and collapse. So always take the dominance and non-dominance of the collaterals, angle and then location. Werner classification, skip it. Favorable and unfavorable in my case is bridging collateral and length of the occluded lesion. There is no bridging collateral, these are favorable. Unfavorable, stump absent, total occlusion, side branch is present, and there is more than 3 months of occlusion. Will take 2-3 minutes, sorry. Make a plan. There are 4 possibilities, and antegrade or retrograde, wire escalation, or dissection and re-entry. This is a common North American hybrid algorithm, very commonly used. And then new terminology, which comes into extra plaque and intraplaque rather than subintimal tracking. And then my plane is ADR, because already it is dissected plane. I started with 7 French of femoral, RC axis. Better to have 2 guiders, one, and another important thing which I would like to highlight is a protective wire in the donor vessel. Then plan the hardware already discussed in details. Then what we do, write a step-by-step plan. Axis, guiding catheter, guide wires. If MC fail to advance, removal of MC wire trapping with 2.5 to 15 in case of 7 French and 2 in case of 6 French. MC fail, 1 balloon, bigger balloon, and then if it is failed, pilot 200 for re-entry and confidenza 12 again for re-entry. If fail to advance, anchoring 1.5 and will be anchored, balloon will be anchored in the side branch. If this fails, retrograde approach, investment procedure, available stuff for complication, snares, coils, everything available, and pericardiocentesis, one should be ready for pericardiocentesis in such cases. Bedside echo should be available. This is the card already mentioned, so I wouldn't waste the time. We'll go, and this is antegrade, retrograde. What I did will show my case, final result if possible. This goes into dissection plane, into the false track. It was not moving, and the wire was Gaia second I used initially, and then I switch I advanced the microcatheter, teleport microcatheter advanced, and then if you look at it, sorry, crossed, 1 balloon was used to predilate, then 2 balloon trapping technique, so many things. So just to cut it and the final result and then conclusion slide. It's very cruel to have such presentation just in 10-minute time. It should be 15, 20 minutes really. So this is the final result, not the final one. Stent, post-stent dilatation, and then final clip. This is the final RCA results. So complication, preparation for complications, this should be in your mind, and then final, but just 1 minute to complete my presentation. Sorry for delay. Fundamental of CTOs, and this is conclusion. Take-home messages. Proper planning and execution is important, number 1. Try to avoid ad hoc CTO PCI, number 2. Dual injection is must, number 3. MC catheter use is important and essential. Support of the guiding catheter is of paramount important, and it's a game changer in CTO. Hardware knowledge, compatibility in systematic approach is important. Always involve experienced operator and other CAT staff. Team approach is essential for success. And then always try to avoid preventable complication, but if they do occur, be ready for prompt recognition and correction by utilizing all available resources systematically to mitigate adverse consequences. Thank you very much for bearing me for extra minute.